This is a conversation with Dr. Phern Chern Tor, psychiatrist and head of the Neurostimulation services at the Institute of Mental Health in Singapore. Dr. Tor is leading the way for the integration of TMS in Singapore and was instrumental in gaining government subsidy for patients receiving TMS treatment in Singapore. In this interview, Dr. Tor shares his insights on the practicalities of running a TMS service, aspects such as avoiding the very rare but more serious adverse events such as seizure, and managing the less serious but very important aspects such as patients' pain tolerance during treatment. And then we discuss the importance of the TMS operator-patient interaction, whether that be a nurse or a psychologist, and also the economic benefit of TMS to society and the patient in terms of quality of life indices, and the place TMS has in a stepped care model of mental health treatment. Here is our conversation. Hi everyone, I'm Dr. Trevor Brown from Neurocare Group, and thanks very much for joining me today. Thank you very much to Neurocare for sponsoring this, and of course, we don't get to bring this to you for free unless amazing companies produce this for us and allow us to speak with fantastic people like Dr. Phern Chern Tor, who is a psychiatrist and head of neurostimulation services at the Institute of Mental Health. So PC is what the friends call you. So how are you going today?
Doing great, Trevor. Thanks for the invitation.
No worries. So you're in Singapore and a couple of hours behind us here in Melbourne. We're going to talk for around half an hour to 45 minutes about TMS. We're going to, first of all, get to know you a little bit, talk about your clinical research, your background. In particular, today, we're going to focus on the practicalities of running a TMS service, especially aspects such as avoiding the rare but more serious adverse events like seizure, managing the less serious but very important aspects such as pain tolerance for patients, and then practicalities such as the psychiatrist's role in assessing suitability for TMS and then monitoring outcomes. And the importance of the TMS operator-patient interaction, something that I heard you talk about very well in London earlier this year, and looking forward to talking about that and getting your thoughts on that. Whether that be a nurse or a psychologist who's actually delivering the TMS. And then finally, we might wrap up with a bit of a chat about the economic benefit of including TMS into mental health practice, its benefit to society and on an individual level. So, as I mentioned, PC, I met you briefly in London this year at the Clinical TMS Society conference. I listened to you speak at their Pulses course, and which I'd highly recommend people attending. By the way, the CTMSS Pulses course is fantastic. And so how long have you been involved with CTMSS, Phern Chern?
Well, I've been a member for probably about 5-6 years, and I started getting involved in the Pulses courses just last year. Actually, I met up with the then President Mohammed Abudani in Portugal. As turned out, we had a nice chat about this, and I was trying to at the same time bring Pulses or an international course into the Southeast Asian region, because it's an area of need where we are, and I'm very happy to have the opportunity to talk a little bit about our experience doing this in Singapore for the past 10 years now I think about it, and anything else that will be helpful for your audience.
Great. Thanks, PC. It's great to have you today. So we're very lucky to chat with you. We won't take up too much of your time. It's very generous of you. I know you've got a very busy day there with patients, etc. So no, it's great. But just very briefly to get to know you a little bit, PC, where did you grow up and what about your education?
Well, born and bred in Singapore, but a little bit of an Australian connection. I first went to Australia when I was 6. My dad was doing a master's in UNSW, and I was there for almost a year in Randwick. Very fond memories of that 1 year I spent in the equivalent of kindergarten, I would assume. Yeah. And then I actually went back to the exact same place to do my fellowship after I finished my training, and that was 2013. So I actually went back to the exact same neighborhood and did a fellowship with Professor Colleen Liu at the Black Dog Institute in Sydney, affiliated with UNSW. Before that, I spent about 13 years in the military, and so I was an active military officer. I was in the Navy. I did quite a lot of things completely unrelated to mental health. I was a submarine medical officer. We did occupational health. We even did cardiology for a while. We set up a cardiac center in Singapore to help with cardiac screening for all our enlistees. At the same time, doing my psychiatry training, and so that's where I came from. And then after I finished my tour, there was a 12, 13-year tour, and then I've been in what counts for the public sector in Singapore since then, working at the Institute of Mental Health in Singapore. And this is a 1,900-bed inpatient hospital with a very large outpatient catchment as well, about 50,000 outpatients. And we're the only tertiary psychiatric unit in the whole of Singapore, which is about 5.6, 5.8 million people. So it's roughly the population of Sydney, or I think New South Wales actually, squished an area roughly the size of Manhattan. So we were pretty densely populated. And that's a little bit about where I came from, my training and my experience, and relevant for you and your audience. We set up the first public TMS service in Singapore in 2015. The private sector beat us to it by a year, and then we've been running it since 2015, and we've helped set up 3 other public TMS services in Singapore since then. And this may be a little bit unusual compared to the Australian context, but we have essentially 4 public TMS services and only 1 private service. And that's something that's been, to my knowledge, a bit unusual. I think in many Western developed countries, the private sector is as active and perhaps even more active than the public sector. But in Singapore, and I found out in the entire Southeast Asian region, because the CTMS, as you mentioned, the Clinical TMS Society has set up an Asian special interest group. We've just connected literally in the past couple of months. The situation in Singapore is not dissimilar to what my colleagues in Malaysia, Indonesia, Japan, and Thailand and Korea also face. So that's a very different situation compared to, I think, certainly in Australia and North America. That might be of interest and perhaps shape a little bit of the practical issues that we've had to deal with, which I hope to be able to share with you and your audience.
Great, thanks. And so you're now the head of that neurostimulation service at the Institute of Mental Health that's been around since 2015. How long have you been the head there since the start?
Since the start, I was the first head. We brought TMS into the country in the public sector. So I was a guinea pig, essentially. we learned a lot.
Wow.
Hard knocks, essentially.
Baptism of fire. Yeah. Okay. So you've learned a lot of lessons along the way, and some of those are, I think, very valuable lessons for people who are just starting up their TMS practice and to learn a few of those things that you're going to share with us today. But in terms of your scope of practice, you do a lot of ECT as well. I noticed you mentioned before your association with Colleen Liu and Black Dog, and now I know there's a lot of research done in ECT there. And I noticed also that you've published on the qualities of a good Singaporean psychiatrist, and I found that really interesting. And what would you say differs or might differ, or what did you find there?
I'm amazed that you actually bothered to check it up, and we actually did that work with an Australian psychiatrist from the Melbourne clinic. It turns out, Dr. Joel Sim, and also with a Korean psychiatrist who we try to make it international. The long story short is that there may be a difference between what a Western developed country considers a good psychiatrist versus a very Asian and perhaps midway Asian society as Korea versus Singapore. And the Cliff's Notes version is that perhaps it's certainly in Australia, where Joel replicated the study. It seems like a good psychiatrist would be a good mentor. So they're essentially almost synonymous. If you're a good teacher, you'll be a good psychiatrist. In Korea, it's quite clear. With a Korean colleague did a much larger survey there. There may be a difference in that a good teacher is not exactly the same as a good psychiatrist, and perhaps there is a difference and of opinion about doing versus teaching. Right? I won't go into more of the data. And in Singapore, it's actually a little bit of in between. There's a difference between what is we think is a good psychiatry mentor versus a good clinical psychiatrist, and basically it's about the ability to get the service done versus teaching. They are not overlapping then as compared to the Melbourne population. And I didn't expect to talk about that, but that seems to be it. The underlying perception may be that people that do research, and that means mentors, teachers, academics, we're this roughly grouped in the same category. And I apologize that it's not, but that's roughly how I think it's conceptualized. May or may not be people that get the clinical job done in an Asian context. And something that's worth discussing and may or may not be relevant for the TMS field, I suppose. Trevor, I hope that answers that question.
No, that's a bit of a curly question for you, but it's nice to get some impromptu answers like that sometimes. And I think it's a really interesting thing because the cultures do differ a lot. I think, and even as you say, between Singapore and Korea, and it'd be really interesting to get a real global outlook on what it means to be a good psychiatrist and the different demands there are. Logistically, but also from a personal, relational perspective as well. I think that differs in an Asian context as well. All right, fantastic. So let's move on. We're getting to know you. You integrated TMS into Singapore in 2015. Is there reimbursement for TMS at all through Medicare or through insurance?
Very glad you asked that question. The answer right now is yes. It took us 8 years to get it. So when it first started in 2015, it was completely unsubsidized, no Medicare equivalent, no government subsidies, and certainly no insurance coverage either. It took, as you mentioned just now, we did some research in quality of life as well as cost effectiveness of TMS to treat depression versus the gold standard, which is electroconvulsive therapy. And because we did that research and we applied many times, the Singapore government finally provided or recommended subsidies for TMS for treatment-resistant depression, January 2022. So just literally 2.5 years ago, very recently. I think it was just a little bit behind the TGA, if I hope I get that right. Was it TGA? No, not TGA. Sorry, your Medicaid.
Yeah, it was. You were just in front of us because I think it was about November 2022 in Australia to get the Medicare rebate for TMS.
Or that we were a little bit earlier then.
Yeah, well, so I may be right.
So it's Medicare, as you said, it's Medicare in Australia. So, but you guys have more coverage. We have a lifetime coverage or subsidy of only 39 sessions. I think in Australia it is 45 sessions, if I'm not wrong, which is still a significant limitation. That means, and certainly in Singapore, and I think in Australia as well, only a fixed number of sessions per patient in their entire lifetime will enjoy whatever subsidies the government will provide. And that there is complexity in Singapore, how much subsidies, but it's only in Singapore 39 sessions in the patient's entire life. And this, for those who are not familiar with TMS, this is significant because depression is a chronic illness, and it tends to relapse when treatment is stopped for many patients. And so for many patients, depression treatment, whatever it is, tends to be either recurrent or chronic. And so when you tell somebody you have 39 times that you can access this treatment, and the standard treatment course is about 30, you're telling the patient that you basically got one shot at getting well. If you need it again, well, you got to pay for it cash out of pocket. And that's our current challenge. At the same time, it's a lot better than having no treatment, because once it became a subsidized or treatment, it automatically became standard treatment. It opened up a whole new vista of, in the public sector in Singapore, funding, and also increased the acceptability of the treatment. Because once our government says something should be subsidized, people are more reassured that this is probably something worth funding and it's not a snake oil, for lack of a better word.
Yeah. Very good. Thanks for that background, and well done for the battle that you fought to get that subsidised. And we need people to pave the way for others later, which you've certainly done, PC, in Singapore. So congratulations. All right. So just a final thing to get to know you a little bit. And this is another out of the box question that I sometimes throw at people, but I'm sure you'll enjoy it. 3 people you would invite for dinner, PC. Anyone in the world, not necessarily in the professional world. Who would that be? Just to invite for dinner, to get to know them, someone throughout history, anyone.
Wow. Well, first, I would love to have dinner with, I hope you know this chap, Neil Gaiman. He is a fantasy writer, wrote a comic book series which I really enjoyed, called The Sandman, and which I think is a Netflix series, and that seems to be an important thing to say these days. Anyway, and he is an amazing author with like you said, out of the box ideas that I would just love to sit and chat and pick his brain about. So that's a little bit of a personal indulgence. I think the second person would be somebody from the TMS field. I've never had a chance to do this, but if I could sit down and have a chat with Professor Mark George, which I think many in the field consider as the father of clinical TMS usage in psychiatry, and just to hear a little bit about his thoughts and his journeys, because he's such an inspiration. The work that he's done is a foundational evidence for essentially most of the field that we're practicing today, and getting a sense about how the world was at that time when he decided to shift the TMS coil from the motor cortex to the frontal lobe, which is talked about publicly. That sort of 5-centimeter forward kind of thinking that changed the world. You just want to hear a little bit more about what that is. Last one, you got to forgive me. This is very trite from a Singaporean. I mean, if I could sit down and have a chat with our founding Prime Minister, Lee Kuan Yew, he's passed on a couple of years ago. That would be an amazing experience, simply because he is one reason we have the country we have today. Still, the controversial figure. He did many things which I think people in the West, what broadly called the West, would find perhaps a bit unusual and controversial. But at the same time, it's worked. And again, being able to just have dinner with him, to have a little bit of understanding of the feel of the man, that would be amazing. Because even though Lee Kuan Yew has literally volumes of his life and history and work published, what is consistently what you can't get on the book and on looking at the television screen, apparently is his sense of presence. And what's repeatedly said by people actually interacting with him is that when he walks into the room, people stop and turn. And that's the kind of thing I would like to experience. And that'll be a great thing to have for dinner. Sorry, Trevor, you've got a psychiatrist talking. It's very hard to shut us up. Thank you for
that. Very interesting. And, I love that question because, we get to know people and obviously, I don't, I come from Australia, a very different background, and that'd be a very, very interesting conversation to have as well. The first Prime Minister with Singapore has obviously changed, a lot of things for the Singaporean people. That'd be amazing. So, great answer. Thanks, BC. All right, so let's get down to talking about TMS. All right. Now, you've been through a lot in setting it up in Singapore. You've learned a lot of lessons along the way. We know that in TMS, it is possible to have adverse events. There are side effects with any treatment, as we know throughout psychiatry. TMS is no exception to that. If we dial up the intensity of a TMS magnetic field, we are going to cause pain. If we do it with a frequency that's very fast, we can cause a seizure if we don't have breaks. So there are different things that we have to be very careful of. If we stick by evidence-based protocols, there shouldn't be a problem, right? We in Neurocare have done tens of thousands of sessions without getting a seizure. But it does happen, and I'd like to talk to you about your experience with it, what the sort of ratio is, what sort of percentage of adverse events do we get, or it's a high adverse events like seizure, and what can we do to prevent it happening and reduce the risk?
Thanks for that. And I'm very impressed that Neurocare has had no seizures at all. We've had one seizure in the past 10 years. And that was something we learned a lot from. It was a young man getting, as you mentioned, very high. He was getting very high dose TMS. He was also in a accelerated TMS protocol. In fact, he was the first patient in that protocol. And exactly what you said. We need to be very careful about sticking within the safety parameters. And the other thing is the ability to pick and risk stratify people, as well as pick up early warning signs. But perhaps since the broad question is, I think, common and side effects and management, common and rare, it starts right at the beginning. And very quickly, there's a bit of a monologue, but just stick with me. You do need a trained and responsible clinician who is familiar with the type of the range of side effects that are that could happen, and have the ability to educate and share the same mental model with what you would call TMS technician. We use nurses in Singapore. You may use psychologists as well, but you say that, Trevor. But the person actually delivering the TMS needs to have the same mental model, be familiar with side effects, and know what to look out for and what are the early warning signs, and be able to communicate that quickly with the responsible clinician. In our case, usually a psychiatrist. So starting right at the beginning, you need to be able to predict the responsible clinician needs to triage and assess at the first assessment the likelihood that this person is going to have side effects. And there's standard things that everybody knows. You screen for a history of epilepsy, a history of seizures. Of course, you make sure that the person has no metal in the brain, that kind of thing. But that's easy. The harder part is when you're talking to the patient, assessing for the patient's number one motivation for TMS. And you'll be surprised that not everybody who walks into the door asking for TMS actually really wants it. And that was something we learned in the school of hard knocks. TMS, unlike electroconvulsive therapy, is only administered to patients who want it, who consent for it. But even though patients consent for it, they don't always want it. Sometimes it may be the mother or the father or the boyfriend or the girlfriend or whatever asking them to do this. And when that happens, the motivation may be low. And when the motivation is low, pain and discomfort tends to be magnified. So one assessed for motivation, just because they sign on the dotted line and they're willing to pay the money and time, doesn't always mean they're motivated. Make sure that they really do want it. Otherwise, any side effect is just going to be magnified significantly. The second thing, besides looking for motivation, is looking for a history of significant side effects with other treatments. And this will come out in a good history. Whether it's literally they already have chronic pain of some kind, they have a history of migraines, history of headaches. If this sort of thing is picked up, you've got to be very clear in your informed consent taking that, well, TMS consists of you feeling like someone's tapping your head like this, maybe 10 to 50 times per second. And if that doesn't scare them off, you've got a chance. And go good. But assessing for the likelihood of pain, a history of pain, a history of migraines, and also, this is a bit less commonly taken, a history of side effects to any treatment that they've had before for depression. Who's going to scope this for depression? If a patient tells you, everything I've tried, I've had side effects. I've talked to a psychologist and they gave me side effects. Then you've got to be really careful. Yeah, we've seen this before. This really happens. They say, well, TMS might have side effects. You've got to make a clinical decision whether they are at higher risk of getting it. So that's really right at the first session. A lot of responsibility is from whoever's doing the intake, who's accepting this patient. You got to do that assessment as part of the overall clinical assessment, not just their likelihood of response, but likelihood of having side effects from this. So motivation and likelihood to tolerability of side effects, and likelihood of having any kind of side effects with treatment. And I must say they tend to go together. The other thing, after that, you need to, at the next step is when you're doing the MT or the resting motor threshold. And that is the first time the patient actually in our setting sees the TMS machine. They have no idea what this actually is, and they experience it. The most dramatic example I have of this second step to triage and assess, predict the likelihood of side effects is I have a patient. She was a middle-aged Chinese lady, a lot of anxiety. I did the counseling, we did intake. I said, I think you've got a good chance of getting better. I open the door, she sees the machine, and she says, I'm not doing that. And she runs off. She literally runs out. She never even enters the room. So if that happens, it's probably not going to work out. And whatever you do to them will probably induce some kind of side effects for whatever reason. But when you also do the MT, if you find there's the patient is wincing away, I usually start by taking the coil, putting it on my hand, making my hand twitch. And then I put it on the patient's hand, essentially mirroring or modeling what I expect them to do. If the patient doesn't want to extend their hand to let me put the coil on after I've demonstrated the same thing, again, high likelihood of having all sorts of side effects, and motivation is probably low because you need to place the coil on their body, otherwise it's not going to work. And after that, I put the coil on my head, I make my hands move, I make my hands switch, and then I ask to do the same thing to them after screening them for contraindications to TMS. And if I give one pulse, usually you start off at a very low dose. For us, you got to be 30% of the machine output, and they jump out of the chair. You know that this is probably not going to work. And I very quickly start steering the conversation to other treatment modalities and other things, or maybe a slow TMS instead of fast TMS. Again, second stage, the actual interaction in the TMS room. If they are not able to tolerate it, the whole idea of having something touch their head and tap them like this is anathema to them. Side effects are going to be very common, even if you push it through to the next stage. Last stage is really the initial couple of treatments. And we find that roughly the first week, with regards to side effects at least, is probably critical. And you may have heard me say this in the Pulses course in London, but you need to go slow no matter what the patient says. Because in Singapore, and the context was and is that they're still paying significant sums of money cash out of pocket. They all know that they're supposed to hit a certain threshold or certain dosage for the full dose. And guess what? Everybody wants their money's worth. And they're going to say at the first session, get to the full dose, get to 120% of RMT. And my nurses used to do that. And we had a lot of loss to follow up. Because on the very first day, we ramped it all the way up. And then they generally finish the first session. And then they'll call back the next morning and say, I've got a horrible headache, I can't come in anymore. And that was it. So we learned, again, the hard way. Whatever the patient says, you need a trained TMS clinician who's able to look at the patient and say, yes, it's all right, push it up more. All right, yeah, I know it's okay. It's all right, we'll go up a little bit, rather than all the way up. So you need a TMS clinician, a practitioner or technician who is able to make a clinical assessment about whether the patient is able to tolerate the current dose or intensity of whatever TMS treatment you're going to give, no matter what the patient says. And it has to be a clinical assessment. And with the basic rule is, if the patient can't tolerate it, TMS is not going to work. So we always go slow, start low and go slow. We try to go up all the way, and most patients you can. But if we need to go a little bit slower, we go slower. And the patient is the one who decides at what rate that's going to go. And that's certainly something we learned. And not surprisingly, when I speak to my TMS colleagues around the world, most people have essentially gone the same strategy. Because if the dose is too high in the first couple of days, the pain is horrible. They never come back. Because the best example is I was doing TMS for one of my psychiatric colleagues as a demonstration. And he kept saying, go higher, it's okay, go up, no problem. It was just a demo thing for him to experience. And 2 days later, he calls me, hey, PC, I've got a horrible headache, is this supposed to happen? I said, yeah, I don't think you should have gone so high, kind of thing. But that was it. He's not patient, so I have no duty of care for him. That's all right. Anyway, so those are the 3 steps. You screen them initially just by taking good history. That's always a big step. You have the TMS initial session, the first contact. You make an assessment. Do you think they are suitable for it? Are they at a high risk of having side effects? Can they tolerate the entire treatment? We're coils on their head for 6 weeks, so to speak. And lastly, the first couple of sessions is key. This is out of the doctor's hands. Usually, you need a TMS clinician, nurse, technician, whatever, who is skilled at assessing what the patient is actually able to tolerate and go up based on their clinical judgment, less on what the patient says they want, at least initially. That's a quick summary.
Advice. Yeah, look, PC, great advice, and like you said, you learned the hard way, and nurses and clinicians, when they take on TMS, will get to know this stuff over the first few months that they do TMS. But it's great to have some experienced clinician on hand as you begin. We did mention serious adverse side effects, but then jumped onto pain. I'd just like to outline the actual percentage risk for seizure, because people might be thinking straight away here, well, what are the risks? Well, they're actually lower for TMS than they are for drugs such as bupropion, and probably similar to antidepressant medications. Is that correct? And are there any drugs that in continuing medication while you're doing TMS, are there any that may lower seizure threshold and increase the risk of seizure?
Thank you for that, and I apologize. You're right. I completely veered off on that. The statistical risk, or the quoted risk for this from the Rossi papers, is probably of seizures or mania, which is the other severe adverse effect, is roughly 3 to 6 per 100,000 treatments. It's been represented in different ways, but it is exactly like you say, Trevor. It is a very low number, and you're absolutely that. We always talk about bupropion. The risk of having a seizure on bupropion is on paper higher than it is having TMS. So it is a very, very low risk, and a low absolute risk as well, so relative risk. And like I said, when you tell patients, we've been doing this 10 years, we tell people it's 3 to 6 out of 100,000 treatments. Nobody jumps out of their chair and says, oh, well, okay, that seems like a low number. The other thing is, you mentioned very, very correctly about what can increase the risk of a treatment, especially remembering that TMS is, as you pointed out, a series of treatments over a period of time, generally about 4 to 6 weeks for most people. And a lot of things happen during 4 to 6 weeks. So one thing is, besides knowing that the risk, you have to manage the risk. You always need to tell the patients during this period of time of treatment, you try to keep whatever treatment you've been on exactly the same, and they understand this. And the most patients who are suitable TMS do comply with. They're investing time and money and effort to do this. So whatever you're on, just keep it on exactly the same. That's not just for side effects management, it's also for good clinical management, because we tell patients, if you are changing, optimizing your medication, having new psychotherapy, and you're doing TMS, 3 things at the same time, and let's say you get better in 6 weeks' time. There's no person in the world that'll tell you which one was useful, or you needed all 3 or 2 of them. So try to keep things the same during the entire period of time. And the other third thing is, you need a robust protocol before every single session. Your TMS nurse or clinician or technician screens through any change in significant things. And this is standard protocol. I would expect most TMS manufacturers would have a checklist and do this, but that'll be sleep, caffeine, alcohol, and change in medication. Last bit, we used to think that if you were on medications like tricyclic antidepressants, you got to be extra careful about any change in dose of that, because the initial seizures together with TMS seem to have an association with tricyclic antidepressants. That has significantly changed in the past, I would say, 5-10 years. And now there's very little, right at the beginning, I used to be terrified if somebody happened to be on a tricyclic and getting TMS. I might repeat the motor threshold for this chap every couple of days. The evidence now is that it matters less what you're on at the beginning of TMS, as long as you keep it on the same thing throughout the entire course of TMS. And so as long as you just ask for, rather than looking out for specific medication that they're on and say, oh no, you're on bupropion, or you're on a tricyclic or whatever, or conversely, or you're on an anti-epileptic agent like valproate, you're fine, you'll never get a seizure. The more rational approach, I think, a simpler approach is check what the medication they're on, get the MT on whatever medication treatment they're on, and tell the patient, make sure you stick on the same thing throughout the entire course. If anything changes, tell the nurse, and the nurse will screen for it anyway. And you need to have a good communication system between your TMS technician and the responsible clinician. And every time a patient has a change in medication or sleep or caffeine or alcohol intake, the nurse will message me. We have a hospital-wide messaging system that's fast and reliable, and says, "Doc, this has happened. What do you want me to do?" Generally, the nurses already know what to do. And sometimes I'll say, "It's fine, carry on." Or sometimes I would say, "Hey, let's dial it down a bit." Sometimes we increase the dose if the guy's taken a couple of Xanaxes just before the session kind of thing. And when we do that, I can't speak to how much decrease or increase of risk or safety you have. I don't think there's a good study that does that. But it's very useful to reassure two groups of people. One is you're telling the patient, we've noted what you are, we've adjusted treatment accordingly. Very reassuring for patients. It's also very reassuring for staff to know that we've got their back and that we are aware of what's happening and that we are taking their feedback and their clinical observations seriously and adjusting treatments. So we change it a little bit. The most important thing is to have a responsive communication system between the responsible clinician and the TMS clinician or the nurse or practitioner, and to have the same mental model about how you approach these things and communicate it to the patient. And that builds trust in that tripartite relationship, the doctor, the patient, and the TMS practitioner. Trevor, over to you.
Yeah, lots of great information there, PC. One of the things that I really took out of that is the nurse having a set of clinical questions that they might ask when the patient comes in. And most manufacturers will produce this. All courses, accredited courses around the world, will talk about this as well. Have you changed medication? How is your sleep? Have you suddenly changed your alcohol or smoking intake, etc., etc.? A question I get often is, in what sort of situation would you not go ahead with the TMS session at all? You might adjust the dosage, as you mentioned there, but in what sort of, if somebody is on bupropion or a tricyclic, if they suddenly stopped it for the day or had zero sleep for the night, would you stop the TMS session?
That is an excellent question. This is a personal practice. I'm not aware of any clinical guidelines or recommendations for this, but the first thing I do is I generally ask the patient or get the TMS clinician ask the patient about their preference. Doesn't mean we want to do it, but the nurses by now know this. They will ask, they picked up something, like you said, something has changed, sleep, medication, whatever, doesn't matter. Something has changed, the nurses will already immediately ask, do you want to continue the TMS today? And they will report that straight away to me, and this is something we have to evolve along the way. The patient's preference is a significant thing. If the patient says, actually, I just don't want to do a TMS, it doesn't matter what they've done, whether it's safe or not. I will pause, cancel, or stop the TMS if the patient doesn't want it. That's number one. And perhaps this is more salient in an Asian context where there's perhaps a little bit more deference to the doctor and a little bit, they may or may not want to tell you they want to stop, for example. But sometimes these changes in things or whatever may be a representation, a way of telling a doctor indirectly that, I don't really want to continue. So we always ask, and the patient wants to stop, it ends there. That's number one. Then you don't want to, we learned the hard way, don't try to push patients to do TMS if they're not sure they want it. You really want patients who are very sure they want to continue. Now, then let's say they say, actually, I want to continue. Then your question comes in exactly, and this is a clinical judgment. It's quite rare. It doesn't happen that often, at least in our clinic. But there are times when the patient comes in and says, I haven't slept the whole night because I just had a horrible fight with my loved one, or it was just, I don't know, I didn't take my sleeping pills and I was tossing and turning for 6 hours in bed. At this point in time, in general, I would, if at all possible, I would go down and assess the patient. It's easier for me because we're in the same hospital. If you're not co-located, then it could be tougher. But ideally, as a clinician goes down, a responsible clinician goes down, makes an assessment of what's going on, takes that away from in my case, a TMS nurse, that reassures the nurse, reassures the patient that something that's been assessed. That'll be the number one step. And how you do that, again, we'll talk about in a while. But if at all possible, do that. If you can't, then you have to do this assessment with your nurse's help, and I will assess the person's baseline risk of having a side effect. In this case, it'll probably be a seizure. I think that's the current focus of the question. What is their baseline risk of having a seizure? If this person's baseline risk is very, very low, and whatever change has happened is relatively mild. They had slept 2 hours less than normal. Carry on, kind of thing. The converse would be true if the patient, and I've done this, I have patients who have had epilepsy or had seizure before, or are still having it, and they consent for TMS, and they get better, thankfully, and they're at high risk, and something has changed, whether to increase their risk of having a seizure, then I would be more inclined to pause or stop. Or if the patient's super keen to continue, I would generally, if it's a fast TMS, decrease the dose significantly. Usually it's arbitrary, by about 5 points of the machine energy to make it a significant drop, and tell the patient, well, you can continue, we're going to try and help you, but I'm a bit worried. So again, that's a pragmatic approach that we've taken. The patient's preference is a significant part of it, but it's not the only thing. You do need to make a clinical assessment about where the likelihood of a seizure happening and based on the patient's baseline risk and what the change has been. And again, there are lots of things that could happen, but sleep is a big thing. Alcohol is a very, very common thing that happens. The other most common thing is a benzodiazepine. Off the bat, very quickly, the benzodiazepine, they take it, they don't take it. Unless they're taking a whopping huge dose, it generally doesn't make much difference. We generally continue. Alcohol depends on what they take and how much. If they're intoxicated, we don't proceed with TMS. I mean, that's a rule. If they're drunk right now, it stops there. If they had a shot of whiskey a night before, not so bad. But they finish half a glass of gin, also half a bottle of gin, then we might ask them to repeat the MT or pause for a while and see how it goes. But the last thing is sometimes the change in treatment, whatever it is, raises seizure threshold or the kind of thing. And then in that case, I sometimes increase the dose by a 1-2% kind of thing. And this is just really to tell a patient that, I'm trying to compensate for it, but I'm trying to adjust based on what you've told us, rather than ignore whatever they just told the nurse and they know that the nurse has just called me about. And that's respecting what's happening. And increasing the dose by 1 and 2% probably doesn't change the seizure threshold that much, but does help helps accommodate or account for the increase in RMT a little bit, and also tells the patient that we are taking what they said seriously.
Thanks. Great to get your experience there, because it is something that people struggle with when they begin. What sort of case do I call off this TMS session? So generally speaking, I mean, we've mentioned motor threshold a lot and RMT. So just to reiterate, that is an assessment to determine at what percentage of machine output is required to stimulate the cortex, and we do this on the motor strip to see a twitch in the thumb to determine at what stimulation intensity we need for that patient at that moment, and that can change from day to day depending on alcohol, sleep, medication, etc. And so we can repeat the MT as many times as we need each day if needed. It's usually done at the start of treatment, and then every few sessions, 3 to 5 sessions. Generally, we do it throughout neurocare. But you can repeat it as many times as necessary to adjust the dose for that day. And so that's a really good way of determining the dose for the day. And we also know from studies in TMS that really it's a hodgepodge of people who are taking all sorts of different medication and interventions who have gone into the TMS studies, because it's determined that TMS is successful with treatment-resistant depression. So these patients are, generally speaking, they're unresponsive to their medication already, and they're just continuing their dose. But we've got all sorts of patients in these TMS studies, and the studies have shown that seizure is unlikely.
Very low.
Very, very low, regardless of those medications that they have been on during those studies. So, but there is no clear sort of rule of thumb for which medication and when to stop a TMS session. All right. So something else you touched on there, PC, as well. You touched on the relationship between the psychiatrist, the nurse, and the patient. And this is something that I really enjoyed listening to you speak about in London. You you touched about the regularity of checking up on the patient, the daily care, the patient coming in to actually see the nurse, of developing a relationship there and a connection between the patient and the nurse. And you have determined that, if my memory serves me correctly, you've got specific nurses that have come on board that have really clicked with TMS, some that haven't. Those that have been able to develop this relationship, because TMS goes over a long duration. There are 35 or 40 sessions, and the patient's coming in on a regular basis. So to develop this relationship is very, very important. Is there some way that we can sort of ascertain or promote this with our clinic, within the logistics of time and money and etc.? Can you speak to that at all?
I'm very happy you mentioned it, Trevor, and I'm glad that aspect resonated with you. And again, this is something that we learned by doing. The human connection during TMS, as you pointed out, is key. It's not just magnetic waves doing its thing onto a person's brain. It is a human being using a therapeutic modality on another human being. It is care simple and straightforward in another way. Instead of giving psychotherapy, instead of giving medication, you are giving, or I would call it, magnetic stimulation. But it's still exactly the same care process, and exactly like what we're used to in psychotherapy and psychopharmacology. That therapeutic relationship with, usually, as you say, it's a TMS practitioner or nurse, rather than doctor who sees them, every now and then, when we have time, kind of thing. That has undoubtedly been a key feature. And so to answer your question directly, how to encourage it? Ideally, you have a small, dedicated team of people that are highly trained, highly motivated, and enjoy interacting with patients. I know it's strange to say this for a mental health population, but not everybody who's working in mental health particularly enjoys that intense relationship with people. And that's just something you have to screen out. So ideally, you need a small team, because the level of training for this and the type of work you're doing here is different from standard medical and standard nursing training. So you need to invest a significant amount of time. And that's why even after 10 years of doing this, essentially we have 7 nurses and 3 doctors who are essentially trained. We have a few more that sort of have an interest, but we realize that you have to have currency as well. So keep that in mind. You may not be able to build up a large pool of people to have resilience in your roster, kind of thing, but you need a couple of people, much more than one for certainly, to A, make sure you have a continuity of service, and B, that you have a small group that's able to support each other. And every single one must enjoy interacting with patients, be interested in their story, and be able to provide for us good nursing care or good TMS care, however you want to call it in your setting. And that requires the lead clinician or the team leader, to be able to select these people, screen them, and say, yes, I think you're good for the team, or B, well, we tried and I don't think it's working out for you for whatever reason. You need to say no to people as well. And it doesn't end after finding the right person who is motivated and skilled and enjoys dealing with people and helping patients over a long period of time and want to build a relationship. You need to continue to encourage and support them. And so you need to, as the team leader, be able to set up a continual process where the technicians who are doing the bulk of the work, 99.9% of the actual TMS work, is delivered not by a doctor, but by a TMS technician or nurse. They need to feel that they are a key part of the team. Regular team meetings, that's not just about administration, but it's also about education as a key part, is key, and also as a feedback session to you hear about practical problems on the ground. And when you have those sessions regularly, you go and find out what's happening on the ground, what are the pain points, and address it. You educate the nurses about the latest in the TMS field, and you get them as much as possible to your level. That, I think, is a synergistic ecosystem to enhance any TMS clinic. I must talk a little bit more about educating your staff. And this is something, again, we had learned on the way, learned the hard way. I used to think I would do amazing informed consent. I would tell the patient and the family everything they need to know about TMS. And that'll be it. And then they sign the consent and I walk off and the treatment is done. I found out to my chagrin much later that most patients would just nod, at least in my context, nod to me very politely to the doctor. After I walk out, they'll turn to the nurse and say, what's he talking about? I don't understand a single word he's talking about. Then the nurse had to explain everything. So if the nurse doesn't say this, doesn't know what's going on, or says something different from what the doctor says, you've got a problem. So we've invested significantly in having regular educational sessions, not just for doctors, which already happens here, I think. We add a lot of it for the nurses to make sure they know what's going on. They understand how TMS works to the best of our knowledge. They understand how the latest technology, how to improve processes, and that has been a key to providing high quality care, because patients will turn to a nurse, and the nurse, because they spend so much time with the nurse, and ask all these questions that they will never ask the doctor, and the nurse provides our team a consistent response, and that has really made a visible difference. They don't have to wait for the doctor to tell them what's going on. They'll turn to my TMS nurse, and they'll get the same consistent answer no matter which nurse they have. As a side effect, some of the nurses actually take on research. So we've had our nurse publish the first TMS paper in Singapore with our naturalistic outcomes just coming out somewhere this year. It took a long time to get it done, but we found that it was nursing-led, nursing-derived, because they wanted to know, are we doing good work? So they looked at the patients, studying on patients, looked at it. It's a small sample, but it shows the kind of results that we're having. We're very proud of that. So that has another positive side effect of building this system, not just to make sure that side effects are low, not just to make sure that the therapeutic relationship with the outcomes from TMS are good because of good TMS care and a strong therapeutic relationship. It builds a stronger team academically as well as from a relational point of view. Sorry, I'll stop monologuing again.
No, great advice. Thank you very much. And I know, look, you're fitting me in amongst your busy day, so we'll get to the last of the points that I wanted to discuss with you. You've mentioned several times this relationship is very important between the nurse and the patient. The therapy process is very long. There's a significant time commitment for patients and the clinic to conduct TMS. So how does one who's a psychiatrist who's been educated in psychopharmacology and potentially ECT, how does one fit TMS into their practice? In what sort of situation would it be appropriate to screen and integrate TMS into your practice and have patients go into TMS? And is it financially viable? Because I know you've done research on this. You've looked at the economic validity of TMS in Singapore. I've read, and I'm sure you have as well, the economic validity quality indexes on in Australia and the US. It's reimbursed through insurance in the US. It's reimbursed through Medicare in Australia, and therefore it's more accessible to people when it's reimbursed. But even in an out-of-pocket fashion, it's been determined that RTMS at the right stage of a patient's journey is actually financially viable. So would you be able to outline what you found in your research and also which steps of the patient journey that you would determine TMS is relevant?
Trevor, very happy to talk about that. And you're absolutely right. This is something that we needed to do. I mean, in Singapore, we use the term cost effectiveness kind of thing to convince the government to subsidize the treatment. And basically, we did 2 cost effectiveness studies comparing TMS cost effectiveness. And basically, cost effectiveness is not just how good a treatment is, but how much it costs. So the basic principle is whatever outcome you're looking for, in this case, antidepressant efficacy, and how good it is making patients' depression better, versus how much it costs to get that benefit. That's the basic principle kind of thing. And we looked at how the cost effectiveness of TMS versus the current gold standard, which is electroconvulsive therapy in Singapore. We did that study. And this is a technical term that my health economist tell me. TMS dominated ECT for cost effectiveness. It doesn't mean TMS was stronger. It's not. ECT is still stronger. The cost of ECT and the side effect burden, of course, was so much higher than TMS, that TMS dominated ECT in the treatment of non-psychotic depression at an ISA level. That's a technical term for incremental cost effectiveness ratio. That's how much you would pay, or rather the government would pay, for 1 year of one good quality adjusted life year. That means one good healthy year. And in Singapore, the cost for ECT to be cost effective compared to TMS will require an additional 300,000 Singapore dollars a year. That's a solid chunk of cash, because the rough rule of thumb is that the government would pay roughly one person's GDP for one good quality adjusted life year. That kind of makes sense. If you make 50,000 US dollars a year, then it makes sense for the government to pay 50,000 US dollars a year to make sure that person's healthy for 1 year. That kind of makes sense. It's way higher than that for ECT. So that was one study. But the other thing that you're asking about is sequence treatments. And there was a second cost effectiveness study that we did, and we were very happy with this. The question was, if you had 4 treatment tries to get depression well in Singapore, what were the 4 steps or sequences of treatments that made the most sense from a cost effectiveness point of view? And the answer was 2 antidepressants, TMS, and then ECT if there was continuation therapy. And so that means that if somebody in Singapore had depression, for the government, the most cost-effective approach for the average patient would be 2 rounds of antidepressants, preferably different ones, obviously. Third round would be TMS, and lastly, it'll be ECT. And you only progress from one stage to another if you didn't respond. And that was very encouraging. I suspect that was one reason why the government funded TMS. And so I would say after failing 2 good antidepressant therapies, TMS, and this is not just our evidence, as you mentioned, evidence from around the world has essentially the same kind of thing. TMS works well in a treatment-resistant population, especially if they fail only 1 or 2 antidepressants. If they fail more, it still works, but it doesn't work as well as if they fail early. And remember, for those of you who are less familiar with mental health treatment, 2 adequate rounds of antidepressant treatments, you're talking about 6 to 12 months of treatment, depending on who you are, which part of the world you're in. But that's a long time to have depression that's not treated. So after that, 2 rounds of that, please move on to TMS, and after that, ECT. It doesn't just make cost effectiveness sense, it makes a lot of clinical sense. You don't want to keep treating and trying your 7th, your 8th antidepressant, which really happens in the world. People are on 7, 8, have tried 7, 8 times before they get sent to TMS. They've been unwell for 3, 4 years, and they get TMS, and a lot of them get well. More than half these patients get significantly better with just 4 to 6 weeks of treatment. So third step for antidepressant, if that doesn't work for TMS, for people with treatment-resistant depression, after that would be ECT. And that kind of, Trevor, I hope that addresses that a little bit.
Perfect. And it's very perfect to know. It's very similar to what happens in Australia. The Medicare rebate is only for treatment-resistant population who has undergone 2 failed treatments of antidepressant medication. And I know in other parts of the world it's very similar. So that answers the question. Thank you very much. I'd love for you to summarize for me, if you could, in a minute or 2, how it was for you setting up your clinic. What were the major hurdles for you in the first year or 2 that you overcame? Just the aspects that we talked about already today. A few of the things like nurses, like adverse side effects, the major themes of today, to summarize for us in a minute or 2 of the take-home message for what you learned in setting up a TMS clinic.
Thanks, Trevor. And I think the clinical pearl, if I can call it that, for people starting up a new treatment is, do it. It's an amazing service when you set it up, very rewarding for the entire team. At the beginning, education, and team building with your team, as well as educating your colleagues who are referring cases to you. We didn't talk about it much, but that's a key part. You educate your team so that they're on the same page as you, they're highly trained. You educate your colleagues to be more aware of this treatment, and they'll refer cases to you, and be a helpful clinician. Try to help them with the most challenging cases, kind of thing. That, I think, is the first step. The other thing is, initially, the psychiatrist or the responsible clinician needs to be there every step of the way to help support the team, monitor extra carefully, get extra feedback, provide extra supervision in those first couple of years, as you mentioned, until the team is confident. And then you know that you've got a robust team. And then they will tell you, Doc, we got to change this. This patient, these kind of patients need that. And then you know that you've got a experienced, well-oiled team that will take it to the next level. That's it, Trevor.
Fantastic. Look, I've loved our conversation today, PC. I could chat with you forever, but we need to wrap it up. And I just want to thank you very much for your time. And I look forward to seeing you again in future conferences. Thank you very much for joining us.
Absolutely, Trevor. Thank you for the invitation. It was a great conversation. I hope this will be useful, and I'll see you soon.
I'm sure it will be. Thank you so much. If you work in the mental health field or you're a budding researcher in neuroscience, you might be interested in some of the other conversations I've had with other experts in the series. Please like, subscribe, and let us know what you think in the comments.